Welcome everybody to the another edition of Oncology Beyond the Obvious. And I must, admire Amish for picking up such a important publication for discussion today. And normally in OBTO we find out a recent publication that we want to discuss. But in this instance, Amish has found out a publication that is several years ago. And about a drug which I think everybody knows right from internship level, not even before MPS is over, internship level also we understand that. But that has such immense application in the oncology space. And the funny thing is that it has not been used on a routine practice in the real world. So today's discussion in OPTO is going to be really path-breaking, and it's going to really awaken the what we are doing wrong and how we should improve on it in our daily practice. So I will not waste much time. I will hand over to Amish to start the proceedings and also the interview. Over to you, Amish.
Thank you, sir, and thank you everyone for joining OBTO. With your support, we tend to improve upon every month. Uh, Today, can I have my first slide, please? So, as we always discuss, I will first present few slides of on the paper what we are going to discuss, and after that, we will start our interview with the stalwart in this field, Dr. Viraj Lavingia, whom I'll introduce further after the slides. And then we will have a panel discussion, which is moderated by Dr. Prasad. And then we will have detailed discussion about one paper. So today we are going to discuss aspirin use in adjuvant colorectal cancer. Involves both colon and rectum. Next slide, please. The article which we have taken, in fact, what Sir was mentioning was 2012 paper, but what we are mentioning today is September of 18, 2025. And this was the first randomized study to specifically address some specific question. And this study is called as Alaska Study Group. It is from 33 centers in Europe and specifically Swedish Cancer Registry. Uh, Low dose aspirin for PIK3 altered localized colorectal cancer in a very, very specific select subgroup of patients. Next slide, please. The journey of aspirin started in 1991. As you can see, this was published in New England Journal of Medicine. Aspirin used and reduced risk of fatal colon cancer. What they studied that if you have taken 2 or more times per week for a year of aspirin, and then does it change the biology of the colon cancer? The next slide, please. Then we got in 2003. This was again a randomized trial to prevent the adenomas, not the cancer, but adenomas, and this was a positive study. Next slide, please. We had next NEJM publication in 2012. This was basically a registry study where there was a retrospective and prospective, and I'm sure Viraj will tell us more about this. But this was the first time where there was a subgroup analysis of PIK3CA mutation and colorectal cancer survival following aspirin use. So before and after diagnosis, what happened? I would leave it to Viraj during discussion. Next slide, please. Coming back to today's paper, so this was September 18, 2025. So 1991 to 2025 journey. Next slide, please. What was the patient population? 18 years and above, diagnosed with stage 2 and 3 colon cancer and stage 1, 2, and 3 rectal cancer. With PIK3CA mutations, they use both hotspot and NGS. Post-operative, by within 12 weeks of surgery, whether patient is on chemotherapy or not on chemotherapy, was started on 160 mg aspirin per day for 3 years. Primary endpoint was colorectal cancer recurrence in group A, that is hotspot alterations in exon 9 and 20 in PIK3CA. Just 1 minute. Sorry, my battery would have died if I don't attach this. Perfect. Primary endpoint was colorectal cancer recurrence in group A. That was the primary endpoint. And group A was hotspot alterations in exon 9 and 20 of PIK3CA. Secondary endpoint was colorectal free recurrence, DFS and OS in group B. That is PIK3CA, PIK3R1 and P10 by NGS and all other points in both the groups. Next slide, please. So this is, I think, small study, but Tarini Sahu taught me that we should always look at the chart. So 6,397 patients were assessed for eligibility, out of which 3,700 patients provided written informed consent. 515 had Group A alterations, and 588 had Group B alterations, out of which 314 in Group A underwent randomization and 312 in Group B underwent randomization. If you see, the follow-up is good. In fact, hardly 1 to 2 patients lost to follow-up. Next slide, please. Subgroup stratification was done only and only for according to stage and group. Stage, whether 1, 2, 3, or Group A or Group B. There was a 3-monthly follow-up of every patient, and the scan, either it was a CT scan of the thorax and abdomen or MRI, was done only at 2 time points in asymptomatic patients, that is at 1 year and at 3 years. In symptomatic patients, you can decide whichever way according to symptoms you need to do the investigations. Next slide, please. This was the characteristics of the patient, Group A and Group B alteration, quite matching in this particular slide. I think there was very well divided between the groups. The right colon and the left colon and the rectum were equally divided. Next slide. This was interesting. The 80% of the patients, 75 to 80% of the patients were of low grade, and high grade were less. One. Second thing is, I want you to remember this. There was total neoadjuvant treatment in rectum cancer. It happened in Group A in 20% of patients, while in Group B, very little in the experimental arm, but 20% in the control arm. Next slide, please. This was again a very, very interesting according to me. MSI high was in 21 to 24% of patients. Normally stage 1, 2, 3, we say 10 to 15% of patients, but these people had high MSI. And if you see the BRAF, KRAS and NRAS, a lot of patients had a lot of co-mutations, which was in practice. Normally, we don't find so many co-mutations as far as I am concerned. Next slide, please. This was the difference. If you see, A and B were Group A and Group B. So this was hazard ratio of 0.49 in Group A, while the hazard ratio was less of 0.42. The aspirin arm in both the arms were 7.7% patient had recurrence as compared to 14% and 16.8% in the Group A and Group B respectively. As the stage increased, or the disease-free survival was better in Group B. So in fact, what they thought that only hotspot will show better response with aspirin, they showed that any PIK3CA alteration, whether picked up on RT-PCR hotspot or NGS, aspirin does help. Next slide, please. Again, this is a forest plot chart, and again, this is very, very important. Rectal cancer, if you see the first highlighted thing, in Group A or Group B, did much better than colon cancer. MSI high, again, did quite well, and the hazard ratio of 0.19, which was really good. And this is something new. I don't think this was expected. Females did far superior compared to males. When they saw this, they tried to do a body fat index and see whether that has any meaning, but there was no meaning of that. Next slide, please. If you see PMMR or DMMR, I have downloaded these slides today morning. Here, the NCCN panel clearly says that if you have T3N0 onwards in colon and in rectum T2N0 onwards, and if there is a PIK3CA mutation after chemotherapy or during chemotherapy, start aspirin 100 to 162 mg daily for 3 years. Uh, can we move to the interview now? Can you close the slides, please? So this was today's paper, and now it is my honor to invite our person whom we are going to interview and going to ask him questions. Dr. Viraj Lavingia. Dr. Viraj Lavingia, I think, has carved out his name in GI cancers a lot. In fact, I think every medical oncologist in India reaches out to him if there is some issue with GI cancers, even beyond medical oncology. People ask him about surgery also, people ask him about radiation oncology also. So Viraj, you are one of the specific and specialist medical oncologists as far as GI cancers are concerned. And thank you for helping so much. Viraj did his MBBS from Ahmedabad, VS Medical College. He did MD in Breach Candy, and he did his DNB, medical oncology, in Apollo Chennai, Viraj, right?
Hyderabad.
Hyderabad. Okay, sorry. Viraj started his love of GI, I think, cancers when he did a fellowship in City of Hope in Los Angeles. I'm sure there. After that, coming back, he was in HCG, and now at such a young age, he is a group director of entire oncology in Shelby group of hospitals, where he looks after the entire India group of Shelby hospitals. And Viraj, congratulations for that, and thank you for joining today.
Thank you, sir. Thank you for very kind words. It's always
Oh.
pleasure to be here with you.
No, no. So, Viraj, let us start discussing. Um, First 5 questions are yes, no, or maybe, as always. Is this paper of 2025 September practice changing?
Yes.
Okay. Does aspirin help in cancer overall?
Colon cancer?
I ask cancer.
Yes, it helps in prevention of colorectal cancer.
Okay. So that was going to be my next question. Does it prevent the occurrence of colorectal cancer, or does it prevent the recurrence of colorectal cancer?
Both.
You feel that it prevents the new formation of cancer also?
So it is proven. Actually, we started with primary prevention, and the secondary prevention, just like we are talking about Alaska, is a subsequent attempt. So primary prevention was always proven.
So
The
primary
secondary
prevention was
prevention, we are
always
proving.
proven according to Viraj, and we'll see that. Uh, Duration in this paper was 3 years, but according to you, should it be 3 years, 5 years, or indefinite?
So it's
Use of
interesting.
aspirin.
For secondary prevention, a short term is enough. For primary prevention, as we will discuss further, a long term aspirin use was shown to have improvement in primary prevention.
Primary prevention. Aspirin for all types of colorectal cancer or only PIK3CA mutated subtype, Viraj?
So, since after this paper, I have changed. I used to believe in all, I used to actually prescribe in all, but I think so I'll have to change my practice.
You'll have to change your practice. Perfect. I think with this, let's come to the paper. It is the first randomized control trial of colorectal cancer in PIK3CA subpopulation. Whereas you agree that before this, there was no randomized of this particular subtype, the
Of a
molecular
molecule,
subtype.
I
Molecule.
completely agree.
So this is a first paper. Okay. Since it is a first paper, if you have to redesign this paper today, Viraj, would you change any methodology of the same?
Uh, it could have been done. So just like you showed us the diagram that how many actually were initially screened, and then out of which only 1,000 patients, only around 600 patients were actually went on to the study. A vast majority were removed because they didn't have PIK3 mutation. You know, if they would also have been randomized to aspirin versus no aspirin, we would have known that does aspirin actually work in all comers or it's only for PIK3. We know it works on PIK3 after this paper, but the ASCOL study, which even Atul sir was part of it, showed that it does not work in all comer, but it was an Asian cohort. But in
So,
the
so,
end,
so Viraj,
they
Viraj,
could have redesigned it.
yeah, I'm
Yes,
coming to that for that. So, if you see the patient population for hazard ratio of 0.5 and below, this number of patients were sufficient.
correct.
So, do you think that, so they were very ambitious that they realized that hazard ratio would be less than 0.5,
Yeah,
but they calculated based on their assumption of hazard ratio 0.5, and they said these numbers are absolutely fine. So,
correct.
do you think that still the number should have been higher, or these numbers are good enough?
No, it's perfect. So, they, like you said, there it was an ambitious attempt. The larger the margin of difference you want to study, the lower the sample size you
Correct.
require, right? So, and hence 600 patients were enough for them to show that by using aspirin, you reduce the risk of recurrence by half. And they actually proved it. Kudos to them.
So, you were talking about from the entire colorectal, your practice was to give in every colorectal, and now on this paper, molecular
Yeah.
subtype. So, from 1991 to 2025, Viraj, do you want to, in brief, tell us
Yeah.
how did aspirin start and where did we land today?
Right. So actually, the story of aspirin is way before my birth also. It's in 70s and 80s, when certain group of doctors from Harvard wanted to ask a question that using aspirin in all individuals. So they started their experiment in nurses and their physicians. And their question was, does it reduce cardiovascular events? So that was the question they wanted to answer. And in doing that, fast forward 10 years, they found that actually colorectal cancer incidence went down by 40% in these individuals. So that was the first sign of proof of concept that using aspirin for longer years, more than 10 years, actually reduces incidence of colorectal cancer in normal individuals like me and you. Fast forward more years, just like you said in 2012, the same group from Harvard then they went on to ask a second question that, okay, we gave aspirin to normal individuals. Few of them would have got cancer, right? So then they took those patients out, that people who actually got cancer despite taking aspirin. Then the second question was, giving them further aspirin for 2 more years, will it actually help them live longer? That means, will it help them reduce the recurrence risk? And the paper that you showed, 2012, the Lau paper of New England Journal, showed exactly the same, that giving 2 years of aspirin to these individuals post-diagnosis actually reduces colorectal risk, and that too only restricted to PIK3 mutation. So generally, all comers didn't benefit. So this was a very, very tantalizing question. So the other investigators from the Europe, UK, and the Dutch wanted to see whether is there any merit in this. So they went back to their data sets and they published again in same few years, couple of years, 2013 and 14, I think. And they showed that aspirin works for everyone. PIK3 or no PIK3 in their data sets.
So, meta-analysis after meta-analysis, and the
Correct.
hazard ratio was
So
0.75 in those
correct.
meta-analysis.
So about 25 to 30% risk reduction in colorectal cancer recurrence. When I was studying my medical oncology, I read that paper. And since then, in my practice, I have always tried to use aspirin for patients who are low risk for bleeding but high risk for recurrence, generally as a blanket. But I think so with this last couple of months, we had two large randomized control trials to prove that that thinking was wrong. The one, Alaska, which we are going to discuss further, and the second was Ascald. You
Called
know,
January 2025. That
yes,
was
so
there.
Alaska got all the clapping,
Hmm.
but it's the Ascald which took the back seat. But I think so it's a far more important trial. It's from Asia. India was part of it. Atul sir was part of it. Tata was part of it. The difference was they gave aspirin to all comers. They were not molecularly selected, and they didn't show any benefit. So clearly, in last 4 decades, we have moved aspirin from primary prevention to secondary prevention, and now as a precision oncology. We're using it as a targeted therapy for PIK3 altered colorectal cancer. It's one of the most fascinating things. I think so. Purvish sir summed it so well, that one of the oldest drug, and we are finding new ways. We're still learning new indications in oncology, and I think so. That's the beauty of this paper.
Right. So I think important point which Viraj told in last 3 to 4 minutes was one always lives to learn more or learns to live more. From all comers in last 10 years to now molecular subtype. I think 2012 and 2025, these two papers and a negative paper on ascalt. I think it seized that it is more of a subtype of colorectal cancer. Is that right, Viraj? That is
That's
what we are
that
understanding.
is what we have to learn. And I think so the next step, what these authors are doing is they're going to collaborate all their data and do a large network meta-analysis to see whether is there any sense in using aspirin for non-PIK3. PIK3 story is done and dusted.
Done and dusted. So coming to in your day-to-day practice, Viraj, how do you do PIK3CA testing?
I don't. Well, now we'll have to start doing.
You were giving in everyone.
Correct.
So
I don't know anybody from our country. If you back rewind 3 months ago, I don't think so. Anybody was ordering NGS or PCR for PIK3 as a routine clinical practice. We
right.
use it for metastatic patients.
Right. So, basically, PIK3CA, if we do a colon panel, like, all these Indian labs, what give Lal Pathology, Med Genome, and Datas of the world, they also include PIK3CA. And PIK3CA mutated, since I have started practicing, I have got one PIK3CA since last 1 month, and I have decided to put the patient on aspirin. But would you recommend, see, here in this paper, they said hotspot
Yeah.
exon 9 and 20,
Yeah.
and then NGS to cover the broader aspect of PIK3CA. Would you recommend a PIK3CA short panel or the entire PIK3CA by NGS?
By NGS, because even in their cohort, the benefit was equally there. In fact, you can argue it was more in group B. So we don't want to miss out that group. And especially in the Scandinavian countries, if you combine both groups, the prevalence was 35 odd percent. That's huge. 1 in 3 patients would have some form of PIK3 or PTEN pathway alteration. And then we want to give them aspirin. So I would do a broad NGS henceforth for all stage 2, stage 3
For
colorectal
all
cancer.
stage two.
Stage 2
The,
stage.
the 5 alterations, if these 5 alterations, they develop hotspot, would you be happy looking doing RT-PCR hotspot and move on within 5 days, you get the result?
I would be happy provided some company has to bring this
Bring this. Okay.
PC
Okay.
category.
So I think right now our bottom line message is that do NGS for all these patients to find out any form of PIK3CA pathway alteration,
That's right.
including PTEN, so that you can offer them aspirin.
That's right.
Fair enough. My next point was, I know you are now, whatever questions I asked, you are going to say subgroup nahi tha karke, but low grade, 80% low grade. There is some paradox here that 80% low grade, but stage 3 benefited better than stage 1. Do you find any paradox here, or you feel that that's okay?
So the second part is the easier part. That was a pre-planned question. That
Hmm,
higher the stage, benefit
correct.
was more. And that's what we would think, that if you have high risk of recurrence, adding a drug actually can show you better results. While in stage 2 and some questions you asked about stage 2 colon, the difference was not much. So that is explainable. It's a plausible explanation. While low grade, so they all included grade 1 and 2 as low and only grade 3 as high grade. I think so in India, we had one paper from South and one from Atul Sir's also. About 35 to 40% of our patients have grade 3 or signet
Correct.
ring. So I don't think so we can take
I'm tired of
Scandinavian
seeing
data.
Signet. I'm tired of seeing Signet as the histopathology. Matlab, I'm actually
Too
tired of.
much,
I'm
right?
sure Prasad will cover in his panel about
Right.
that.
So I do agree that in the Europeans and especially in the Scandinavian countries, they had the better colorectal cancer patients.
So my point, I'm asking you this question because in India, assuming that we have say 40-50% high grade, you think the results would not change, right? It will
As long
still show
as
the same
PIK3 would
result.
be there, it should not
It
change.
should not change. Perfect. Coming to MSI high, again 20 to 25% were MSI high. Not a single Indian paper has reported this high MSI. You think anything, although MSI high or MSI stable, the aspirin efficacy was exactly the same.
Correct.
But do you think that so many co-mutations like BRAF, V600E was 20%, KRAS mutation was 55%? Do you think that so many and 37% of PIK3CA out of the cohort, does it reflect the Indian data? You have worked on this, Viraj, earlier.
Correct. So, yes, in India, at best, if I have to guess, and that too is metastatic because we don't have any data set from early colorectal from India, as far as I am aware. But in metastatic disease, our prevalence is around 14 to 15% of PIK3 alteration in stage 4 colorectal cancer. So 37 is something I don't know whether our tests are not good or we are testing in stage 4, which can change the biology, or we are different than Scandinavians. Any of the three is likely answer. Um, but MSI high, 25%. I think in stage 1, 2, 3, if I have to put a number, it should not be more than 15%. I'm doing MSI high for last 6, 7 years in all patients. I'm not seeing this high. 1 in 4 patient is not MSI high, certainly, at least in my practice. There was one paper from, I think so, Bishwajit sir in gastric cancer, where his data set showed more than 15% in gastroesophageal cancer. I was very much surprised, but I don't have exact information about, different registries from India. But
From India.
at
Okay.
best, it would be 15%.
Right. Next, I'm combining next two questions. Rectal cancer, the hazard ratio was 0.23 compared to 0.45 in colon. And somehow in females, it was hazard ratio of 0.25 and men, it was 0.75. Uh,
Very
just,
important. So
just
the
what do you decipher out of two?
So the first one is again explainable answer that even, and that applies more for Indian patients. We have more rectums than more colon cancer,
Correct.
and they tend to be bad. They require neoadjuvant therapy. Um, so higher the risk, better the result with aspirin. And so stage 3 rectum would get the highest benefit. Stage 2 colon, on the other hand, would get lowest. And that's what you showed in your paper. That's what we saw in Alaska. The second point about male versus female, actually in cardiovascular trials, they found the same analogy that patients who weighed more than 70 kilograms, the benefit of aspirin was not there because the dose, because we were using flat dosing.
Correct.
So it was not being enough. So females tend to had lower weight compared to male, and that's why all the discussion about weight in and male female in the Alaska paper.
Correct.
But that doesn't mean tomorrow male with stage 3 rectum, I'm not going to give aspirin. I'm still going to give aspirin. These answers will come, and mind you, this was only 600 patients, not like 60,000 patients. Such epidemiological remarks should be made on thousands of patients, not hundreds. And so a meta-analysis would be very helpful here. And I'm
Okay.
sure they will answer this question.
Right, perfect. I think if the paper does mention, Alaska does mention about the body fat index, and they found there was no correlation. And they were also trying to find out why females did better, so better than males, but not there. Number needed to treat, you would agree, is better as the stage goes on, which is there. Coming to my second last question is 4 life-threatening SAEs in aspirin group, and there were 4 deaths reported in aspirin group, out of which, according to investigator, only 1 death was attributed to aspirin. Whereas your personal experience, because since 2017-18, you have been giving aspirin to all comers, your personal experience about the aspirin side effects, have you faced any place where you were sort of,
Yeah. So I've had my patient get a stroke, and it was my wrongdoing because he was an elderly gentleman, and I was being more ambitious in that. So since then, we try to, in my practice, objectively categorize patients into low risk bleeding versus high risk. And since nowadays we all have calculators in phone, we use that has blood criteria. If you have high age, or stroke, or liver disease, kidney failure, NSH, blah, blah, blah. If you have any of these, I'm not giving you aspirin. If you don't have this, you have stage 3 colorectal cancer, I was prescribing them aspirin. So that's a reasonable and more practical way. Low risk of bleeding, high risk of recurrence. I think so. You are okay in giving them aspirin, but now on, I'll have to start testing PIK3 and give aspirin to only those individuals.
So a female who has a rectum cancer of stage 3, where you know hazard ratio 0.3 and a moderate to high risk of bleeding, would you give aspirin?
Difficult, right? See, and when we say we use aspirin in India, we all use 75, just
Yeah,
left,
so
right,
they
center.
say 100 to 160 is what NCCN says.
Correct.
Is
So
the 2 tablets of 75?
even yesterday you said 150 after we dariye. So even giving 150 is a challenge sometimes, right? So
But so would you give 75? Would you give 150?
no, I use 150 because
I think all of us after this paper will use at least 150 or 100 to 150 because
yes.
75 is too less a dose. My last question to you, because I know you are categorically mentioned that it's a practice changing paper, I will not repeat that. You talked about primary prevention. Show me one randomized paper where the primary prevention of cancer, colorectal cancer by aspirin has happened, and my interview would be over, Viraj.
So no, I agree. There is no randomized trial. And usually primary prevention trials are epidemiological studies because you need almost 15, 20 years of follow-up in thousands and thousands of patients. And the Harvard group actually tested aspirin for more than 1 lakh individuals, nurses and healthcare professionals. Interestingly, when they tested it 5 years later, there was no reduction in colorectal cancer. When they tested it 15 years later, and suddenly their hazard ratio popped less than 0.6. Um, so that is the single most piece of evidence. And then other European data sets show the same finding that over the years, and especially the Swedish and Norwegians, they have national data sets for 40, 50 years. They are showing us that a long-term aspirin use reduces colorectal risk. And so we, even in internal medicine training, we used to say,
So where do you use primary prevention as of today in 2025? Lynch syndrome only or all comers? You are just finding an excuse to start aspirin.
that's the best answer. Find an excuse to prescribe aspirin, and there you go.
There you go. Okay. So I think we have that said that aspirin should be used in PIK3CA mutated all stage 1, 2, 3 stages of whether colon or rectum with or without chemotherapy. And as of now, for 3 years, and try to use 150 mg. Try to see the bleeding risk. If there is a very high bleeding risk, think twice before giving aspirin.
That's right.
I think this is the conclusion, and we would use NGS for all PIK3CA,
In
right?
early stage, yes.
In early stages. Perfect. Thank you so much, Viraj. You stay on. Back to Parikh sir. Viraj, you are still a panelist. Back to Parikh sir. Okay, I think sir is probably dropped out. So I would invite Dr. Prasad. Dr. Prasad is very, very dear friend. Looking at Prasad, I never realized ever that he has completed 50 years of his life. I thought Prasad must be in 31, 32 years of age. And again, the journey from doing DM in Tata Hospital till now, going to Dubai and then coming back again to Indian soil. I think Prasad has seen a lot of things. And one thing, very good thing about Prasad, which I like, is he digs deeper into whatever he does and he tries to do it in detail. So over to you, Prasad. And can we have the slides for panelists? Yes. So we have Viraj who will continue as a panelist. डॉक्टर घनश्याम बिस्वास घनश्याम दादा को जो नहीं जानता है प्लीज ड्रॉप आउट हो जाए अभी अतुल सर आर डियर सर he has taught I think half of the generations of DM medical oncologist. Dr. Lalit Sharma, medical oncologist in Jaipur. Abhishek Raj is another, I think, enigma of medical oncology. If any of you want to listen from him, his journey of fitness, like Prasad, I was flabbergasted listening to him. In addition to that, he does a lot of BMT and treats cancer also. Dr. Tanvi Sood is a medical oncologist. She is recently shifted to Dubai. Dr. Aditya Sarin is a medical oncologist in New Delhi. Aditya is, I think, the most vocal and the most enthusiastic of medical oncologists as of today, what I have seen. Over to you, Prasad. Prasad, you have 50 minutes.
Yeah, thanks. Thanks, sir. So great opportunity. I did not dig deep, I should confess on this. And sir, this are all the panelists there? I didn't see Dr. Aditya and Abhishek. I can't see the. Do you? Are you sure they are joined the link?
I have this Sophia would tell मेरे पास जितना है उसमें आदित्य एंड वो अभिषेक तो नहीं दिख रहे हैं.
Okay, fine. So
Abhishek sir he will try to join after 15 to 10 minutes, sir.
Aditya will also join, is it?
Aditya? Aditya?
So if they are joining, if someone should inform me, because then only I can.
Right. So you have right now 4 panelists with you.
Right. So the slides are visible?
Yeah.
Yes.
Yes, sir.
Yeah. So we will start with Dr. Tanvi. Have you read this article in full?
Good evening. Hello.
Hi, Dr. Tanvi. How is Dubai?
Well, I do miss India, but not so bad. Not so bad. It's like India. It's like being in India, actually.
So have you read this article in full? Because Viraj was saying that this is practice changing and it should change our practice. So have you read this in full? Have you critically analyzed this article?
Well, I'll be very honest. I have gone through the synopsis and I've gone through the tables. Yes. I want to deeply go into the discussion part of it also. I've seen the highlights where the women have done a lot better, because my interest was why have certain, subtypes of population perform better. So that's the answer I was trying to look for within the article. And as you know, the interviewer and the interviewee before our panel have very nicely highlighted that this kind of data has existed from before. And once I got this invite is when my attention truly went to the article, I'll be honest, because I took it as another evidence where, aspirin is of use for us in colorectal cancers. And as Dr. Viraj has mentioned, a longer duration perhaps in primary chemo prevention, primary prevention strategies. And even NCCN does guide us that there is perhaps some role of aspirin. It says 325 mg per day, though, for secondary prevention for our patients. So I've gone through the article looking for these pertinent answers. Why are some patients benefiting more, subgroups benefiting more than the others?
Sure. Atul sir, so you have done the study also.
Yeah.
What in a decade or so, or in 15 years, what has changed in your practice? Do you actually counsel your patients regarding this data, and do you select patients for this intervention?
So simple and the short answer, I'd say that I have not been counseling a patient about this article because I have not been doing pick 3. Simple. That is the
Right.
probably in adjuvant setting in this thing. We did participate in, like Viraj was mentioning about this ESCOLT study and this thing, but that did not require the patient to have pick 3 or COX2 or any other mutation.
Sure. Dr. Lalit, what about you? Do you actually practice this in your routine practice?
Well, if you say regarding the practice of prescribing ecosprin for secondary prevention, so far we were not doing this, and after this data has been highlighted, we are more inclined to do that. And if you are asking about doing PIK3CA evaluation in the early stage, no, none of our patients were being evaluated.
Right. Dr. Bishwas, what about you?
So really speaking, so I haven't been doing a PIK3CA. Even in an advanced setting, so most of our patient goes for KRAS, NRAS, BRAF, HER2, and MSI. So PIK3 was not a part because these are 5-gene panel. Unless and until patient who is doing the whole CGene panel and leave about the early. So I haven't done any patient as far as I remember.
Right. So, Viraj, now coming back to you, because I was very interested in your comment that aspirin in primary prevention, secondary prevention, and now being used as a precision medicine practice where we are selecting based on PIK3CA. How do you see this evolution? Do you and why should what is the mechanism where PIK3CA is a group where aspirin is going to make a difference?
So, excellent question. Aspirin initially, like you saw that we were giving for all comers because we found some benefit. Then we found that actually in the PIK3 mutated people, patients, you have this increase in prostaglandins production, which is where the COX-2 inhibition, especially a broad COX-2 inhibition, would reduce that inflammatory markers and actually help in reducing the what we call not metastasis, it's the word progression, the proliferation of the cells.
Right.
So that was a simple understanding, and they found that any pathway of the PIK3 alteration in the colorectal cancer, these increase in prostaglandins are there. They are responsible for inflammation and proliferation. And somehow, if you cut them down, there is a reduction in the risk of relapse. Uh, and same principle that there is a reduction in occurrence of colon cancer. And the same principle was used for CAP1 and CAP2, which we didn't take time to discuss. We also use aspirin and other agents like Sulindac for reducing polyp burden for patients who
Right.
are
Right.
FAP or
I will come to that. Yeah. Yeah.
right.
Yeah.
So it's the same principle. We want to reduce the inflammation and the adeno. So it only reduces the adenoma carcinoma sequence wala colon cancer. So if a colon cancer is happening without that adenoma carcinoma sequence, that you're not going to alter.
Okay. Dr. Bishwas, you have raised your hand.
Yeah, Viraj. So I have a patient of oligometastatic. So new adjuvant taken, surgery done. Patient took adjuvant. So he's PIK3 mutated. So he's disease free. So should I offer aspirin for this patient?
I would do that.
Okay. So we will continue with the discussion. So when I tried to whatever Dr. Amish said about digging deep in this, I found that the trial which Atul sir was part of and the trial which we discussed, and there was a small trial which looked at the similar group of patients. Two of them were selected with PIK3CA pathway. One we discussed in detail now, and the other one is a small trial which and the large trial which would have answered this question probably, which included 12 countries, Asian, Australasian, and now and unselected population with large sample size of 1,400. Actually, it was the trial which Atul sir was part of. Atul sir, do you want to comment on this trial? How was your experience in participating in this trial? Why did you participate in this trial?
All right. So basically, before I say something, maybe that tomorrow onwards, if all of us start practicing this paper, what it has taught us, and ordering PIK pick 3, then the this molecular lab should be grateful to Amish for selecting this paper.
Yes.
All right. So on the other side, I would say this was the Escort was this idea originated by one or two scientists or physician scientists in the Oxford, when we used to have a this thing collaboration while I was at Ames Indocs, basically India and Oxford, and they started developing this idea. So ultimately, Singapore people, NCI Singapore people took over this, and Dr. John Chia, who probably the lead author or first author, started this thing, and the trial was funded by NCI Singapore. I think this was a simple study, simple in the sense that probably we just wanted the patient to have completed adjuvant treatment, and within 3 months of that, we probably patient would be randomized after completion of the treatment. There are subtle differentiate between the Escort and Alaska. So in the Alaska, I believe patient were randomized after the surgery and to be started on aspirin, whereas in the Escort at the end of the adjuvant treatment. That was one of the difference. Second thing was that the dose. So I think we use 200 milligram compared to 160 milligram this thing. That was. And all of these patients, our population had all the adjuvant treatment, whether rectum and this thing. That was the third thing. And most important difference, I would say, the our primary endpoint was the 3 year disease-free survival compared to, I think, whatever they said, colon cancer specific. That obviously indirectly would mean the DFS only. Trial was simple, and we did not require patient to have upper GI endoscopy. Should be, I think, inclusion excellence well listed in this thing. And it was a simple trial monitored by one of the Indian CRO for Indian. TMH and AIMS probably did contributed a lot, and that's it. And in my personal experience with regard to the trial, because if you read that paper in this thing, incidence of major GI bleeding was only 3 out of the 750 odd patients who were randomized to aspirin arm. So no major toxicity compared to what one would be thinking about the 200 milligram for 3 years of aspirin and this thing. That was not there.
Sure, sir. So I will come to the toxicity part of it. So this is the outcome data from the 3 trials which I could find on this, of which I think the small trial we can ignore because it is so small in such a to answer this question. But the 2 trials, the unselected trial, the Ascalt actually did not show a significant improvement, but the Alaska, as we said, as we saw, showed an improvement in the PIK3CA selected patients. So the summary, if you take from these trials, the Ascalt, no statistical significant, diverse population was there, excellent safety, as Atul sir just mentioned. Alaska, there is statistically significant reduction in recurrence. The other study was small. So let us come to the questions on this actually. And some subgroup, I think this is, let us discuss it. So Dr. Tanvi, can you comment on these 3 studies? We always try to answer our questions based on randomized control trials. Can you critically look at these 3 studies and what do you take away from the 3 studies?
Right. So, first, of course, the premise of doing a study like this or studies like this, we're trying to look into what are the populations amongst colorectal cancers which would perhaps benefit from aspirin. Second, of course, the dose, what would be the correct dose, and also the duration. And these have been the pertinent questions even in the primary prevention space. Now, coming to the secondary prevention space, what we are addressing right now, when I look at the Alaska study, which is the main study that we want to discuss also, primarily it has selected, it is a pre-selected population where we are already seeing patients that do have a proven PIK3 mutation or somatic variants of as such, like Group A and Group B. And we are particularly focusing because we have data based on earlier studies, even though not randomized control studies, but there are already concept forming studies as well as scattered studies that have proven that there is efficacy of using aspirin for prevention of further adenomas and also advanced colorectal carcinomas for patients that are called high risk individuals. That is, they already have a diagnosis of colorectal carcinoma or adenomas from before. So, looking at the structure and how the study has been designed, especially the Alaska study, it's a randomized control study. It is clearly selecting patients that have the PIK3 mutation already. And it's also looking at the dose, as we were already discussing, which is 160 mg per day, which probably to my mind, I feel that the dose is also a second very important question that has been discussed through time, whether for primary prevention, higher doses are said to be more effective, and especially for a longer duration, like 600 mg for 10 years or more than 10 years. There were studies, I'm digressing a bit, but there were studies where, a higher dose seemed to be effective for primary prevention at 10 years, and then at 18 years there was a women's health study also that was conducted where 18 years actually ended up showing that there was perhaps a reduction related to colorectal. So that was always a thought process, practically speaking, in our practice, whether the kind of doses that we suggest, what kind of doses can we suggest to a patient, and also balancing it with the side effect profile. So, to my mind, the Alaska study looks like the well-structured study because of the number of patients, the pre-selected population, the dose that perhaps would be, suitable for an individual who's already recovered from a cancer and has to go ahead with a surveillance and also a secondary prevention strategy, keeping in mind that we want minimal to no side effects and most importantly, the bleeding tendencies that we are always very concerned about, especially peptic ulcers and very low incidence of even intracranial hemorrhage that is hypothesized but not really shown in these studies. So for me, as compared to all comers study like an ASCOLD or Alaska study, which is focused on a population where we know definitely this drug works, this seems to be a more convincing evidence at this point.
So,
Prasad, Aditya Sarin has
yeah,
joined.
right. I got that message. So, Aditya, are you, I mean, we were discussing the Alaska and the ASCOL study. You are aware about this, or you want to have some brief before I ask you a question?
No, please go ahead.
So, you are aware about the data, right? So, with this
Yeah.
data, are you convinced about that we have to of getting a PIK3CA mutation done in colorectal cancer patients and then giving them the aspirin benefit?
So let's see. I think we already had some notion that few drugs which are non-oncology related drugs, which are affecting your inflammatory cascade, that includes, metformin as well, and sometimes these aspirin drugs as well. The evidence is there in, literature, where a lot of, big studies, prospective and non-prospective, both the setting is there. They have definitely showed some, anti-cancerous effect, but we have never been able to dial down that which is the exact subgroup where these medicines can really work. And obviously, this Alaska, where they have been able to prove that the PIK3CA mutant population, if you give them, obviously the benefit is there, and so much so that even NCCN agrees to the point. So, if I were to summarize that, if something is there in NCCN, I mean, to challenge it is one thing, and looking at the subgroup analysis, it becomes completely different scenario. The rest of the trials, you see, if the SAC it was closed prematurely, and obviously the benefit was not statistically significant, even though their trends were showing improvement, but they closed pre-hand. And the ASCOT trial, you can see that in the benefit of aspirin was clearly not there. So yes, the benefit of aspirin is there, but the select subgroup, it's only the Alaska trial which has been able to find out and give the data to us. And I think more trials should be done from Indian setting if we were to go in concordance with that trial subgroup subset.
Okay, so this takes me to the next question. Viraj, do you see you mentioned about larger studies which are required? So this DFS and OS improvement, and Dr. Amish also can join in this question about the hazard ratios. How many patients, if you want to do an exclusive Indian study with this point, and we want to select patients with PIK3CA mutations, what do you think will be the study population?
So if let's say I have to design a study for India, this is how
Yes.
I would do.
Mm.
I would do 2 by 2. One section has a PIK3 mutated tumors, and they are randomized to aspirin or no aspirin. And the other section is PIK3 non-mutated, and they are also randomized to aspirin or non-aspirin. Of course, for people who are PIK3 mutated, there our statistics would be, because we want to assume that there will be 50% reduction in the risk of relapse. So the number required in that section would be just close to this 600, 700, 800. While we know that, we don't know, but if we assume that based on the earlier studies that aspirin works in all comers by 20 to 25% risk reduction, then the cohort which is PIK3 not mutated, I would need around 1500 to 2500 patients to be randomized 1:1 to aspirin or no aspirin. This is how I would design a study in India. And then I think so short 3-year follow-up is good enough, because our primary endpoint is recurrence or no recurrence. OS, of course, would take a long time. But
Right. I
even
think Amish, Dr. Amish, so do you agree with this 2 by 2 factorial design? Do you think that you are okay to consider after getting this trial data with which most of the panelists agree that PIK3CA mutated patients should be considered for this? Do you agree with Dr. Viraj that we will give aspirin in PIK3CA non-mutated patients also after this publication is there?
So, Prasad, first of all, 2 by 2 factorial is a very straightforward, simple design.
Okay.
And if you see the loss to follow up, there is only 1 to 2 patients who have lost to follow up in each 4 groups. Second thing is, I think, all the panelists or all of us, if we go into the details, like Viraj explained beautifully well, we have had these signals since 2000 till 2025. That, one of the thing with Viraj and I, we were discussing yesterday that in familial adiposis poli, this will not work. But in Lynch syndrome, this will work because you need inflammation for aspirin to work. So I think that is the first thing what we need to see. Second thing is, like Viraj said, if you see in a stage 2, stage 3 colorectal cancer, the 90% of the relapses would happen in the first 3 years. And that's why the 3 years follow-up was defined. And that's where they have said the recurrences are less. Now, if you go for overall survival, then you will need 7 to 10 years. If you see, I was just today morning pulling up my colorectal, one of the seminars I had presented 9 months back, and NCCN guidelines at that point of time also said that aspirin should be used. I think probably before this trial even had come. So I feel there is enough data in last 10 years for us to say that this molecular subtype is something which benefits from aspirin. And when have you last, Prasad, seen 0.5 and below hazard
Yeah,
ratio?
agree.
When?
Yeah.
So I think Atul sir wants to say something. My personal feeling is a very simple, straightforward study answering us very specific question, and we should start doing it if we have not started doing it.
So, since Atul sir, so I will ask Atul sir this question about what is the minimum follow-up. Amish just said that 3 year. Amish and Viraj feel that 3 year and disease-free survival can be endpoints here. So, I want to get your suggestion on that. Get your your comments on that, as well as any other comment you want to make on this.
So first,
Okay.
probably before going, so maybe I answer this question and then I have a comment, or maybe I would like to ask Viraj. So it has been long agreed that probably based on the data long time this thing presented many years ago, that the 3 years DFS is probably considered a surrogate for this thing, colorectal cancer OS and this thing. So this is, I think, kind of settled that 3 years is good follow-up. A 3 year DFS or recurrence free or whatever you call it, the situation may be, is adequate. That's no doubt about that. That is one thing. Second thing, I've questioned to Viraj. So since now we have the ESCOLT study, they are going for the SYNPIC 3 and the COX2 and other this molecular marker. But I'm sure they will find little difficult because they don't have the sample for all the patient, I believe so. So why he is thinking of 2 by 2, which include basically group non-3 mutant or this thing genomic changes patient?
Yes,
Viraj?
excellent question. So there are two large data sets. Of course, they are retrospective, but we know the Netherlands have each and every individual in their computer. Whatever you do, how much tablets are you being prescribed every week, it's there on your computer. So that's how strong the database is there in Netherlands. So in Netherlands, when they looked at their data sets, their use of aspirin for secondary prevention showed hazard ratio of around 0.7. And when they tried to see whether, okay, was it only restricted to PIK3 or was PIK3 getting enriched? And the answer was no. And the similar experiment, the UK guys did it, all for British Island. And they had almost 1,500 patients of colorectal cancer. Everybody was given aspirin. And again, the hazard ratio of 0.7. So two large studies showing a similar hazard ratio, and an identical answer that PIK3 was not a decider. So when the Liao in 2012 paper, what Amish sir showed, said that okay, the benefit was only in pick 3, they were never replicated by any other investigators. And hence, since then, as an individual, I have been practicing aspirin for all comers. Of course, now with Ascalt coming in and RCT always trumps, RCT is an RCT. But still, passing it away of all these 10, 15 years of knowledge, I think one more trial would not hurt us. In India, only Tata and AIMS alone can pull in 1,500 patients within a year. So
That also is not possible. Can I ask a follow-up question to Viraj? Since you have been using it for quite some time now, as trained in all patient,
yeah,
so colorectal patient basically. So
low
do you
risk,
have, yeah. So
low
do
risk
you
of
have,
bleeding.
yeah, I know that is agreed upon. So do you have any rough idea of this thing, or did you get a chance to analyze those patients, maybe 50, 100 of this thing, in case the patients, how did they do
I would have
compared to us?
about not more than 50 patients, sir. I would have
Oh,
about 50 patient data set.
how did they do compared to historical control or this thing? Obviously, this will be probably
Correct.
generate a
But I like to
hypothesis.
believe that, my patients are not relapsing. Now, whether that's
Okay.
aspirin or, God's luck, I don't know. But of
So
course, that's
we
not
will
the
move on.
scientific way to
I
look
think
at it.
we will move on this. And so Virat just said that once we have RCT, that is a be all end all of it. But I don't think so. We always want more data, and that is
Right.
where meta-analysis comes. And when you talk about 1,500 patients, we can also look at more than 200,000 patients in this meta-analysis. So this is what I pulled out actually, and I realized that there is the hazard ratios, when you take the meta-analysis, they are not looking as great as the hazard ratio of selective PIK3CA mutation patients. And the overall trend, what we see from here is that there is definite improvement, or there is something which aspirin is doing in these patients for sure. But whether this is strong enough for us to change practice is something which we should discuss. So if Dr. Ghanshyam Bishwas can take up after seeing this chart and the discussion on the randomized control trial data, Dr. Ghanshyam Bishwas and then Dr. Lalit Sharma, on your opinion after on the use of aspirin in this group of patients, I'll keep this meta-analysis chart in front of you. Can you please make your comments on this?
So if I am able to do a PIK3CA for all my patients, so definitely from stage 1, 2, 3, and as Biraj said, even if the oligometastatic with the curative intent, so I'll start using this drug. Though I was using for all comers for few, especially younger patients, and my dose was probably 100. So maybe I can start using at least 150 milligram from tomorrow.
So, Dr. Lalit.
Sir, so me also for pick 3 probably I do not have any reservations anymore. The data says speaks for itself. But for all comers, low risk, low bleeding risk, or patients needing aspirin for other indications where they can derive advantages, definitely no doubts I would go ahead with that. But had there been more data for the other patients also, especially in our population, now we see in these trials that probably the ethnicity does matter, and these patients are somewhat different from our scenarios. The pick 3 mutation incidence is also more, the MSI status is also very different, and in our populations itself, we are a vivid population as a nation also. So if we could run another, if there could be more data, maybe probably we would be more wiser for all comers.
So all of us need more data, and we are never satisfied with what we have. So we all discussed about the bleeding risk and the dosages of 100, 75, 150, 200, 325. We are all concerned because of the bleeding risk, which we always have a concern. So this is the data from the meta-analysis. There is definite significant increase in different kinds of bleeding risk actually. Upper GI bleed, major hemorrhage. The intracranial bleed is not significantly increased, very almost similar in both groups. Fatal hemorrhages is also not there. So let us also see the bleeding risk specific to the intracranial hemorrhage. I think Dr. Tanvi was mentioning about it when she was discussing it. So hardly any intracranial hemorrhage reported in the ASCALT or Alaska or the SAC trial. So very 0.2 percentage, I think, can be ignored. So with this, I think the safety part, let us discuss with all the panelists, and we'll start with Viraj because he has been using it for a long time. Viraj, what is your concern? I mean, why we should not give in some patients? What have you seen as a other than, I mean, you discussed bleeding specifically and also anything other than bleeding?
So the bleeding is the only thing. I had one patient with extradural. That patient was not careful, hit himself and had EDH. And the
At what dosage actually?
150. 150.
150.
So I use that Hasbled score, which is on our phones nowadays. If it's low risk, I tend to offer them. That's my practice until now. But now we'll change it to PIC3 based.
So you are, I mean, you will change it to PIC3 based you because you are giving for all before, and you are giving it based on the risk stratification for bleeding from the score, right?
Right. But now with the Ascalt coming in,
Yeah.
there is a big question that does it work in all?
Right. Atul sir, can you comment on the safety part, the bleeding, any other bleeding other than the intracranial hemorrhage? I am sure that it is very small, but other bleeding, do you do any specific interventions in these patients before you start them on in the trial? Did you do anything like that?
No, as I said during the previous this thing comment also, we did not do. I think that if they obviously just the history taking any major bleeding in the last 6 months or so, or basically any other this thing contraindication for aspirin. Other than that, there was no specific intervention, no specific investigation were done. I just
Okay.
ask couple of panelists. So when we prescribe aspirin in the routine practice, all of us done have MD medicine, might have seen cardiology practice, and also how many times we ask patient whether there is any bleeding risk or this thing, or we evaluate for that.
So I think so if the patient goes for a surgery or any procedure, then we ask them to stop for 3 to 5 days. Otherwise,
Exactly. So otherwise we don't usually ask for this thing. So maybe that because of the trial we are little more this thing observant and particular, but otherwise routine clinical practice we don't ask before prescribing.
So, Dr. Aditya, your comment on this older versus younger adults and whether you do some evaluation, some scoring system as Viraj was mentioning before you start aspirin?
So obviously, I have not been using aspirin. Obviously, maybe I am the outlier here, but I have not been able. Somehow, I was not very convinced in starting prophylactic aspirin. With obviously the trial coming up and finding that this is the particular subgroup, I may change my thought process. But up till today, to be honest, I've never given aspirin in any of the colorectal patients that I have.
So you are not convinced about it.
Outlier.
Yeah, right.
So
Good.
I just wanted to add to
Yeah,
that
Tanvi.
actually.
Yeah.
Yeah,
Okay.
if I may.
Yeah,
So
sure.
even I have not been routinely prescribing aspirin, even in secondary
So I think, sir, let's
prophylaxis
take a
because of
vote. How
mixed
many of us
data.
has
So I
really
wanted to ask
given?
that how many are routinely prescribing,
Yeah.
No,
just to get an
other
understanding.
than Viraj, I don't think anybody is prescribing.
Amish sir,
If
Okay.
someone,
Amish sir.
Because from the panel discussion, I understood that everyone's writing, and I was curious, like,
no,
okay,
no,
then
no.
why am I not writing? You
No,
know?
no.
I
I have been doing this for last 3 months now. Because as I said that I presented in one of the conference, and that time I realized, and I have got one PIK3CA and one stage 2 colon cancer who's not going to get any chemotherapy. So I'm going to prescribe aspirin, and the patient has agreed. I'm just waiting for this patient's surgery to cool down.
But
So
for
that is
all
something
comers,
which,
sir, or is it only for
no,
PIC3CA?
only PIK3CA, only PIK3CA,
Okay.
not all comers.
So
I'm
we
still
had
not convinced about the primary prevention data. Viraj is convinced, but I'm still not convinced, except there is a Lynch syndrome where we can discuss with
yeah.
patient and start aspirin. But otherwise, I'm not convinced about primary prevention, but secondary prevention, definitely.
So regarding the Lynch syndrome data set only, I just wanted to share that we actually have had one tumor board discussion where the patient, was a diagnosed case of Lynch syndrome, and then we were particularly discussing whether there would be benefit of keeping the patient on an aspirin secondary prophylaxis, which is why I wanted to ask.
Absolutely.
First of all, to highlight that it's not routine practice, otherwise it doesn't go to tumor board. This was a very case-specific discussion in the context of Lynch syndrome, where we know the chances of developing a secondary cancer is much, much higher. And all the data that we had looked in, very mixed, like CAP2 protocol or CAP2 trial as well, which was looking at the, I think, primary prevention for Lynch syndrome patients. We were not really able to find any data that, pushes us in terms of risk versus benefit, that whether aspirin, giving aspirin prophylaxis is going to indeed help for the Lynch syndrome patients in terms of a reduction. And second thing was the dose. So the dosage, from my understanding, 600 mg or 325 mg, 600 mg in the trials, but 325 mg as per NCCN guidelines also. And this trial is talking about 150 mg, which is
Yes. So 160 mg to be precise about this trial, Dr. Tanvi.
Right.
But when we discuss so much, and Prasad, I will take your permission. Adjuvant pembrolizumab in RCC, the hazard ratio was 0.83.
Yes.
And adjuvant atezolizumab in colon cancer, if I'm not mistaken, Viraj would say, I think hazard ratio is 0.75, yeah, 0.76. Here we have 0.5 and below, and in fact in females 0.29. And we are still asking each other, are we changing our practice or not?
So which is why I said Alaska is very
really
convincing. It's RCT,
Yeah,
PIK3 directed.
Yeah.
That's also the hypothesis. But I just wanted to highlight about the dose. If we are practicing it routinely, and what dose were we already giving, just to get an
150
understanding.
mg, 150 mg should be this thing. If you see 1991 NEJM paper, they have said that in diary, if you have used 2 doses per week, more than a year, you get some benefit out of use of aspirin. 2012 NEJM, as Viraj very clearly mentioned, and I didn't go so much into details. He told me yesterday that all these patients were anyway receiving aspirin. They developed CA colon, and then they saw that in PIK3CA subpopulation, if you continue using aspiration, you still get a benefit. So I think this subgroup is something which is amazing, and I feel we should not miss the opportunity of using that. Over to Prasad. Sorry.
So, Viraj, since we are on the bleeding risk and the doses, so if somebody has to give 325 milligram of aspirin, now I don't know how many patients we will prescribe 325 milligram. Is there any molecular predictor for serious adverse event, where we can say, okay, this test can tell you whether you will have aspirin-induced bleeding or something like that?
I'm not aware of that. We know that aspirin's bleeding risk is dose dependent. And like Dr. Tanvi said, we have CAP3, which will be read out soon. That is answering whether 100 milligram is enough versus 300 versus 600. And the early answer is yes. Perhaps some data sets are saying, even for Lynch, I have more than 10 patients of Lynch who are on aspirin for at least more than a couple of years. And the significant reduction in the adenomas that we see it's proven. So CAP2 was a positive study. It clearly showed reduction in adenomas and subsequent colorectal cancer development. So in patients who have high
This
risk,
question, yeah, sorry.
So I was focusing on the dose actually. It was 600 mg in CAP2.
600.
That was my question.
I don't
But
remember
will
any
you ever
patient.
use 600?
No.
Tell me
That's
that.
what, sir.
Will you
Which is why
ever
I
use
wanted to ask:
600?
is everyone writing that dose?
even
Because these are
even
the
if it
data
shows
we
a
had.
major benefit, I
So
don't
how
think
did
any one
everyone
of us
come
would
to
use
conclusion
600.
of 150? Sorry, I
Yeah.
mean, I'm openly asking because the data we have that shows positive impact. The doses are so high; it's a bit scary,
So,
to entertain the thought.
I will ask this question to Amish sir, since he was almost hinting that we are not using aspirin because it is a very easy and less expensive drug. So if you want to focus on, I'm not asking about the design of the study. What is that biomarker-driven study you want to do? Is it PIK3CA, and it's almost the same pathway COX-2, PTEN? What do you want to do as a biomarker and to do CRCM? Because remembering GS Bhattacharya sir, I mean, maybe so many years back, also we have always had discussions with him where he used to say COX-2 inhibitors and colorectal cancer treatment. I'm sure Amish sir will know this. So
Yeah.
why this aspirin research is checked there only?
No, so it is, now we have two trials, 2025 में January में Ascald, which is negative because all comers, and now this thing Alaska September 25 only in PIK3CA. I think the evidence, we have to follow the evidence what we have. The evidence says that I would do PIK3CA and MSI in all stage 1 to 3 colorectal cancers, period. Matlab, these two I would do. If MSI is high, again, you know what to do because the treatment changes. And if PIK3CA is high, you have a category 1 recommendation now in almost all the guidelines to use aspirin between 100 to 160 mg.
Sir,
If
if you have both,
sorry?
If you have both MSI high and PIK3CA.
If you have both, then you follow the guidelines. And even if you, in rectal cancer, if you have given immunotherapy, you can follow it up by aspirin. And in case if you have given chemotherapy after surgery in MSI high, you again follow it up by aspirin, because this particular Alaska trial also said that in MSI high in group B, the hazard ratio is 0.29, Aditya. So the point is whether dMMR or pMMR, PIK3CA mutation with MSI high, you would give immunotherapy if possible, followed by aspirin.
Right, sir.
Okay, so one question
Prasad,
which
you have 3 minutes more.
I know that is, so this is my last slide also. So I was just looking what I have. I think most of the questions which I wanted to ask, I have asked actually. So Viraj, any final comments on future of aspirin trials, or anything you want to comment on?
I'm not aware that anybody will do a trial on non-selected population anymore, a randomized trial. The best data set that we can hope for now is the meta-analysis of all these large trials. Let's wait for that. Until then, it should be prescribed only for PIK3 altered colorectal cancer.
So final question is to Dr. Amish,
Prasad.
1 minute. One question
Sorry.
to Dr. Bishwas. Last one question to Dr. Bishwas is that the NCCN recommendation says a patient to discuss with a patient about the pros and cons of the data and take a combined decision. So Dr. Bishwas, tomorrow morning you have a patient. What are you going to counsel the patient about the benefits of this? This is a PIK3CA mutation is not available. How will you help a patient take this decision? How much are you convinced on this actually?
So early cancers we are doing at least MSI. So now, as Amish rightly said, so we should ask for MSI and PIK3CA. Because if you see the PIK3, I was going to a literature, in the right-sided colon cancer, which is more aggressive than the left side, the incidence of PIK3 is almost twice as compared to the left side.
Okay.
So, the right side colon, which is more aggressive disease. So at least, so this is now known that so these patients will benefit. So at least from tomorrow, besides MSI, so we should counsel for doing these patients at least PIK3, because I was just looking at last four colorectal cancers. So none of them had a PIK3.
No, so last four colorectal cancers, you must have done the panel in a metastatic disease, Ghanshyam.
No, so one of them is a young 50 years who just finished adjuvant. On a first follow-up, he had a metastasis.
That's what. So these are the patients, we normally do colon panel in a metastatic disease, Ghanshyam. Otherwise, we try to do colorectal patient today comes to us, we immediately go for MSI by IHC. And if MSI is negative, in rectum, we go for TNT, MSI is positive, we go for, IO. But at least I was not doing PIK3 in early stages. Now I have started doing PIK3 in early stages.
And how are you doing it, Dr. Amish? What are you doing?
NGS. So this
NGS.
colon panel covers PIK3CA. Now again, this I remembered 2 months before Tarini and I, we were in conference and he asked, कि sir 5 type के PIK3CA है, do you see them in details? I said नहीं Tarini, अभी तो मैं positive negative देख रहा हूँ करके. But this paper, Group A and Group B alterations have shown exactly the same. So I would say any PIK3CA pathway alteration, and we can offer aspirin. So Prasad, I wanted to ask Viraj and Atul sir both. Atul sir also mentioned, do you think that somebody who has a PIK3CA alteration and COX-2 expression is higher, like in rectal cancer, they will benefit better compared to PIK3CA, assuming if we have PTGS2, that is what is equivalent to COX-2. Do you think that that will add on to our use of aspirin and the hazards would be still lower? Viraj and Atul sir.
So Alaska did not study that. They did not evaluate PTGS2 and COX2. And ASCOLT, like sir is saying, whatever samples they are having, they are trying to search these questions. They have not even done PIK3 so far, but retrospectively they are trying to answer this. So I don't know. Theoretically, it makes sense, right? It should have more better inflammatory control with aspirin, but you never know until you test it. So it's just an hypothesis.
Just a hypothesis.
Yeah.
Atul sir, you mentioned about COX-2 expression.
Yeah, so unless we have some data from the escort and this thing, I don't think that it's going to, which way it's go. It's just anybody's guess, I would say that.
And sir, why is this paper not changed the practice till now? Because the NCCN is there. I just want to know our mindset.
I'll
That's it.
come to that.
Nothing
I'll
else.
come to that. I'll come to that. And I would like to thank you. I wanted to have this as a parting or last comment at this thing. Thank you very much, Amish. I think maybe that because I blame myself as well, including most of us, I think. So maybe that sometime we probably might be, you mentioned the hazard for that is, though you mentioned for Pembro and this thing. Sometimes we come under the influence directly, indirectly under the pharma drug. And this is very, very inexpensive. Nobody is promoting it. So probably it hasn't reached to the people, I think, the way it should have reached.
Right.
Because 180 cost for 180 one this thing, Pembro and this thing, you can easily get it done. Even if you have to get it NGS through any panel and this thing, it won't cost more than whatever the one we are paying for the 180 or this thing. So that is something, a commendable job you have done, Amish, today by enlightening many people and if all the panelists and the people who are joining today.
So
Thank
I
you,
At-
sir.
second that
सर एक
actually.
अगर वीफा से कोई गिफ्ट भेजोगे तो मैं ना नहीं बोलूंगा.
ठीक है, ठीक है,
Atul
ठीक
sir,
है.
Atul sir, any thoughts on like interchanging aspirin with celecoxib?
Yeah, there is that question. I
So
didn't
once
plan
we have
the
the
interview,
COX-2,
but right.
so once we have the COX-2 data, maybe that will make some sense.
Okay. I think there was one negative paper with Sulindac, as Viraj mentioned, and there was one positive paper with celecoxib. Viraj, I'm not very sure.
Yes, so I know the data for patients who are at high risk. That means FAP, Gardner, Lynch. There, Sulindac works. For secondary prevention of general colorectal cancer, I'm not aware that we have a strong data set to substitute.
Okay, perfect. I think we are at 8:25. And Prasad, thank you so much for doing
Can I
wonderful
have
job.
one
And
question to Dr.
yes,
Viraj?
yes.
So, Viraj sir, so apparently now you have been giving this drug to so many patients. Will you, from tomorrow onwards, call every one of them and tell, to all comers that you need no need of aspirin, only pick 3CA? Do
Yeah,
you stop them?
That
Will
is
you
a very
call them up?
important question.
very nice. So yes, excellent question. Yeah, the threshold for stopping becomes very low. Then you've done it, and now you see any hesitation, you said okay, band kar dete hain. Versus the new patient would only go if there is a pick 3 alternation.
I think
You
very,
cannot
very.
say that, oh, galti ho gayi, abhi band kar
No,
do.
no,
But
obviously,
you have to just
nobody,
No,
nobody says it.
and Viraj, those who have started, like, Aditya, till 2025, till we had one positive, one negative randomized control, the literature, I searched criticism, I searched review, I searched what will you do. Everywhere it is said that it is a gray zone, whether all
Yes.
comers would
so
you
it's
give
not a
aspirin.
done and dusted
So
story.
Yeah, it
I
is not
think
a done and dusted story.
from the
So
realm of epidemiologic significance of aspirin, we have taken it to a prospective precision significance of aspirin.
absolutely, you are so right.
Correct.
Yeah, thank you so much, everybody, and I thank all of you. So every second Tuesday of the month we do OBTO. Next OBTO, second Tuesday of December, we are going to discuss one more controversial, that should we do away with surgery in a localized MSI high, all solid tumors, all comers? Should we stop doing surgeries in these? And that would be the topic. And I welcome all of you to attend that and participate in that. If Parikh sir is there, I would request. Yes, sir. Sir, you are there. Sir, last parting comments from you. Sorry, sir.
No, thank you very much. I think my comment in a lighter vein will be for what Aditya was asking Viraj. And the issue is that when we have discussed about change in treatment plan with patients, we have to keep the medico-legal aspect into consideration. So never ever say, like Viraj said, don't ever make a statement that we made a mistake. Yeah. But other than that, excellent discussion. Absolutely amazing. Thank you very much.
Thank you. And see you next month, all of you. Thank you so much. We can close the webinar now.
All right.
Thank
Thank you
you.
very much.
Thank you. Thank you.